Okay. Good morning. Good afternoon, everyone. My name is Anna Hundt Golden, and I'm a Senior Director of Global Market Access and Value Insights with Magnolia Market Access. And I'm excited to welcome you to today's webinar, Navigating Social Determinants of Health to Improve Patient Access. Today's panelists are Jessica Duchen, Senior Director of Real World Evidence and HEOR Strategy, and Tracy Baroni Allmon, Vice President of Policy and Market Access. Today, they will explore the complex relationship between social determinants of health and patient access, and will provide insights and actionable steps that manufacturers and other stakeholders can take to enhance health equity. Feel free to utilize the chat for any questions or comments that we'll cover at the end of today's webinar, and I'll hand it over to Jess and Tracy.
Thanks, Anna. As Anna mentioned, we will be talking all things SDOH today in relation to patient access. Let me go to the next slide. So we'll start by kind of giving an overview of what social determinants of health are, how they can be measured, why they're important, and then get into some examples of how we've incorporated social determinants of health into our own work. And then Tracy will finish up by sharing an application of using social determinants of health in the oncology space. So what are social determinants of health? So these are non-medical factors that influence our health, and they are an increasing focus in the healthcare space. They interact kind of as a complex web and ultimately influence our health status and health outcomes. And the CDC in Healthy People 2030 defined SDOH as the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. And as we'll see throughout the course of this presentation, social determinants of health are a huge driver in health outcomes and have been estimated to drive up to 80% of health outcomes. And when we think of social determinants of health, we can think of 5 key areas, but again, as we'll see throughout this presentation, they are very complex and interwoven, and don't exist in silos, but influence each other greatly. And just to reiterate, social determinants of health influence all aspects of a person's life, And these include some of the things that you might most commonly think of, like age, race, and gender. But importantly, there's a lot of other factors that as you can see in this graphic here. So things like access to food, educational attainment, your work environment, for example, like in the COVID-19 pandemic, people who were essential and frontline workers was an important determinant in your risk of disease. The conditions where you live and work, your employment status in general, your access to clean water or sanitary conditions, access to healthcare services, and the type of housing that you live in. And in this table here on the right, you'll see just some common social determinants of health characteristics that we'll talk about in this presentation. So we know social determinants of health exist, but it's really important to understand why they are important. And addressing social determinants of health is critical for achieving health equity. And health equity is the state in which every person has the opportunity to attain their highest level of health. And it's important to understand that this isn't the same as like health equality. It's not saying that everyone is going to have the same health status. It's just that everyone should be able to be as healthy as they are able to be. And social determinants of health are key drivers of health inequities, which prevent people from reaching this health equity state. Social determinants of health, as we discussed, are estimated to drive up to 80% of health outcomes. And some studies indicate that our SDOH and where we live and the things that exist around us and influence us have a greater have a greater impact on our health than genetics or, our doctor alone. Additionally, social determinants of health are a top priority for government agencies. So as we mentioned, they're one of the 3 focus areas for Healthy People 2030, and were included in the 2023 HHS Call to Action. And here we can see that health equity has become increasingly a top priority for government agencies and payers. They influence health disparities, as we mentioned, which are these avoidable differences in health between specific segments in the population and ultimately lead to a state of inequity. And it's important to note that social determinants of health and health inequities cause significant health costs to the U.S. health system and economy. For example, SDOH and health disparities are associated with $42 billion in lost productivity per year. And then some estimates say that inequities in the U.S. health system cost the U.S. health system approximately $320 billion, or $1,000 per person. And estimates say that in 2040, this could eclipse $1 trillion or $3,000 per person in higher healthcare spending, lost productivity, and premature death. So we can see that social determinants of health are a problem, or can cause problems for people, reduce access, and result in this state of inequity. But the only way we can address something is if we can measure it and see the impact that it's having. So when we think of how to measure SDOH characteristics, we can assess them across multiple levels. So the first is that we can look at it at the individual level, which would be things like characteristics of the individual or personal habits of the individual. We can look at household characteristics, which are the characteristics of a household in which a person or family resides. And then finally, we can look at the area-based characteristics, which would be the broader environmental factors such as neighborhood resources or community support that influence health outcomes. And each of these, types of characteristics is going to have its own trade-offs. So for example, individual characteristics would be the most specific to the individual, while area-based would be the least specific. And we can capture social determinants of health across all 3 levels and incorporate it into research and access work. So to start, individual measures include some of the things you might commonly think of when you think of social determinants of health, like race, age, and gender, that are specific to the individual. But they also include things like employment status, educational attainment, marital status, personal health behaviors like tobacco use, alcohol use, or risk behaviors an individual might have. Household or family characteristics include things that are specific to, an individual's family unit or who they live with. And these include things like number of people in the house or household size, languages spoken in the home, household income, household economic stability, access to information or internet access within the home. Access to transportation could be at both the individual level or at the household level. And we can measure these individual and household SDOH characteristics in a number of ways. Some that you might commonly see, especially, if you, visit a healthcare provider, is you can see these questions incorporated about your individual lifestyle or your household in your patient chart, or captured in a provider visit. You might be administered a survey as part of a study. There are also these things called ICD-10-CM Z codes, which I'll cover in a couple slides, or we can link to secondary data sources, which I'll also cover in a later slide. And considerations in looking at these characteristics, this is going to be the most specific, and it is potentially customizable if you're interested in looking at, a specific disease and specific characteristics, but this is going to be probably more resource intensive than using an area-based SDOH measure. And our area level SDOH measures are shaped by the underlying factors in the areas in which we live. They're often publicly available, meaning that they're going to be less resource intensive, lower costs, and they can be linked to individual level clinical data based on components of an address. So you'll see here the way geography works at the census level is basically where our areas are all divided into smaller and smaller units that fit into one another, and each of these units is assigned an ID, and we can use components of someone's address to link them to the ID of the area that they live in. So, so with someone's zip code, we could link them to their county or zip code and get the characteristics of that area. So as I said, these will probably be publicly available and cover a wide range of measures. They'll be less resource intensive because they are publicly available, but because of that, they are less specific and cannot be as customized. And then the geography level that you can capture is, of course, dependent on the information that you have available. So someone's whole address will be more specific than just someone's state, but there are, of course, HIPAA and privacy concerns with capturing someone's whole address. And as we said, they do cover a wide range of topics. So for example, the US Census and American Community Survey covers a huge range of topics. And some common ones you might see are percent of residents in an area living below the poverty line, percent by race and ethnicity, the number of vacant homes in an area, percent in an area with access to transportation, or average household size. Other US agencies put out data that are publicly available and might be relevant to specific diseases like air pollution levels, or access to grocery stores or transportation. And then finally, the CDC and other agencies put out these kind of indexes, which take a wide variety of measures and create like what you can think of as a vulnerability score or some sort of composite measure of social determinants of health to figure out the areas where people might have the least resources or have the most predisposing characteristics for lower access. And next, I just wanted to share some case studies that we've done looking at social determinant of health characteristics in EMR or electronic medical record disease cohorts. So in this analysis, we linked our individual and household level social determinant of health characteristics, which were available from consumer marketing data, and we linked that to our in-house EMR data and identified 5 disease cohorts: HIV, chronic kidney disease, heart failure, type 2 diabetes patients, and metastatic prostate cancer. And the goal was to try and see if we could include some of these traditionally unavailable measures in real-world analysis. And as I said, we utilized EMR data and social determinants of health data and identified patients in each cohort. And we first started just looking at some of the more traditional SDOH measures that you might think of, like race, age, and gender. And what we saw is that, the race, age, and gender makeup differ across disease cohorts. And some of this is as you would expect. For example, we saw that, the majority of, or entirely all metastatic prostate cancer patients were male, and the majority of HIV patients were male. However, we did see that racial diversity was greatest among patients with advanced CKD or HIV and lowest among those with metastatic prostate cancer or heart failure. HIV patients were younger and metastatic prostate cancer patients were older, again, as we would expect, thinking about the course of disease. And as we saw on earlier slides, social determinants of health encompass more than race and age. So we were also able to take a look at household characteristics in our data. And interestingly, we saw that over 50% of metastatic prostate cancer, type 2 diabetes patients, and heart failure patients were married, while CKD patients and patients living with HIV were less likely to be married. And similarly, type 2 diabetes patients and CKD patients had the highest household size and were more likely to live with children in the home than the other disease cohorts. And importantly, we can look at these social determinant of health characteristics about the household alone, but we can also create these composite measures which can help us identify populations that may be more likely to need additional assistance in managing their disease. So for example, here we looked at age and living status. So first you'll see patients age 65 plus living alone, patients aged under 65 and living alone, and patients who were married and or living with children, so not living alone. And what we can see is that HIV patients were most likely to be under the age of 65 and living alone, while heart failure and metastatic prostate cancer patients were most likely to be over 65 and living alone. And this could, be an important consideration if you're looking at a disease area where it affects older patients and who might need social support in order to manage their disease. And again, as we've discussed, social determinants of health also encompass the socioeconomic characteristics of an individual. And our data included information on the 2022 annual household income. And we looked at it across these 5 disease cohorts. And kind of what we found the most striking at first was that across all disease cohorts, the majority of patients had a household income below the median US household income of $74,580. But aside from that, we also see disparities in household income when we look across these disease cohorts. So metastatic prostate cancer patients were most likely to have an annual household income over 100,000. Again, this is probably associated with, the age and gender distribution that we saw on an earlier slide, while HIV, CKD, and heart failure patients had the lowest annual household income. Additionally, individual level measures that are usually available in the EMR or claims data include these ICD-10 CMZ codes. And these are reason codes that are non-reimbursable, non-medical, and they're supposed to code for factors that may influence a patient's health status. They became available in October 2016, and there's really been slow adoption, but increasingly we're seeing providers better understand that these are required documentation and that they can be beneficial to include. And we see a higher prevalence of them in the claims data than we do in the EMR data. And part of this may be driven by the fact that some state Medicaid programs and other payers require providers to include these for patients to be eligible for benefits. And specifically, the Z55 to Z65 terms are considered these SDOH factors. So we took a look in the same analysis and looked at our HIV patients and looked at the Z codes that were present there in the claims data. And interestingly, we saw while the adoption was low, about 25% of patients in our HIV cohort had a Z code that allows for us to maybe start doing some subset analysis. So you can see here, almost 10% of patients had a code indicating a high risk behavior, which could be used for a subset analysis or combined with other characteristics to fill in missing data or to better understand our patient population. Great, and now I'm going to hand it over to Tracy.
Myself off mute. Thanks, Jessica. If you want to go to the next slide. We're going to spend a little bit of time talking about what equity and inequity looks like in oncology care, including representative SDOH factors. According to the National Cancer Institute, or NCI, cancer disparities are differences in cancer-related measures that include number of new cases, number of deaths, cancer-related health complications, survivorship, and quality of life after treatments, screening rates, and stage of diagnosis. And so we'll talk a little bit about each of those throughout the next few slides. We know from various studies that the burden of cancer continues to disproportionately impact racial and ethnic minorities and medically underserved communities, including those identified as sexual and gender minorities. For our discussion today, I'm going to break this down into 3 groups related to cancer care, 3 topics: screening and diagnosis, treatment, and clinical trials. And this slide just lists some of the barriers impacting patients of diverse backgrounds to a greater extent than patients without these factors. As we go through the slides, I'll mention some of the actions manufacturers can and are taking to narrow the gaps resulting from SDOH in cancer care. Next slide, please. Cancer disparities among racial and ethnic minorities are driven by a complex interplay between structural and social drivers of health, as well as biological factors that are attributable to genetic differences between population groups and to comorbidities. Due to structural, societal, environmental, and economic disadvantages, certain U.S. population groups carry a disproportionately high burden of cancer. Nearly 20% of U.S. cancer diagnoses are estimated to be related to excess body weight, alcohol intake, unhealthy diet, and physical inactivity. Individuals can reduce their risk of developing cancer through behavioral and lifestyle changes, which we all know is easier said than done. However, the presence of numerous negative SDOHs contribute to significant disparities in the prevalence of risk factors and the ability to impact these modifiable risk factors among socially, economically, and geographically disadvantaged populations. So when we think about this, think about the studies that show that the high percentage of people with negative SDOH that live in areas where they can safely take a walk or buy healthy food. These are the types of things that are easy to modify if you have access, but if you don't, then they're harder. Next slide, please. Screening and early detection includes tests and procedures that find precancerous lesions and cancer in earlier stages when they're easier to treat and more potentially curable. The U.S. Preventive Services Task Force, or USPSTF, one of my favorite acronyms, recommends screening for breast, prostate, cervical, and colorectal cancers for individuals who are at an average risk of being diagnosed with these cancer types. This is usually based on age. However, USPSTF also issues screening guidelines for individuals who are at an increased risk of being diagnosed with certain cancers, which in many cases are those impacted by SDOH, particular employment circumstances, habits, heredity, diet and exercise are some of the major ones. As we see in these statistics, there are several SDOH factors that need to be addressed to improve screening, from transportation and the need for decentralized care sites to communication and appropriate education to insurance status. Manufacturers can narrow the gap in screening and early detection by engaging in specific patient and physician education in conjunction with governments and health systems, including in rural areas and care deserts. Also by sponsoring screening vans, health fairs, other local screening initiatives, and by collaborating with patient groups on screening initiatives. Finally, manufacturers should support legislation ensuring reimbursement for screening. For a couple of these slides, I'm going to add some outside the box ideas. Outside the box means you should definitely check with in-house counsel before pursuing the opportunities that I'm listing, because they could have significant impact, but could also probably be worked out if you have the right arrangement in place. Coupons and patient reimbursement for screening. Is there a way to work on that through various partners within the system? Collaboration with screening companies, which can sometimes be easy if all you want is a listing in the standards of care, but can be more difficult if you want to do something more involved. And insurer and manufacturer agreements related to screening reimbursement. Those are all outside the box ideas where you may be able to find some traction with the right contracts and the right understandings between the parties. Next slide, please. Delays in treatment occur for various reasons. The statistics in this slide point to potential language barriers, lack of culturally competent care, and possibly the impact of the inability of patients to access care due to insurance and transportation issues. A study looking at delays in treatment due to COVID indicates that vulnerable populations are likely to be impacted by these delays for a longer period of time and to a greater extent than other populations. Treatment that is the standard of care should not just be available to patients who have access to a center of excellence or to a major academic institution. According to a report from the ACS Cancer Action Network, 49% of patients surveyed had biomarker testing at the diagnosis of their cancer, while 29% said they had not, and 22% were not sure. To be clear, biomarker testing is the standard of care for certain cancers. Those most likely to have had biomarker testing include patients with higher incomes, younger patients, and those with higher education. Recent data show that racial and ethnic disparities in cancer outcomes can be eliminated if every patient has equitable access to guideline adherent care. As related to delayed treatment, I don't think manufacturers can actually impact the delays between the initial diagnosis and getting an appointment to begin treatment. But once a prescription is ordered, the manufacturer can utilize their PAP, hub, and specialty pharmacy data to track the prescriptions to avoid further delays in accessing medication. Manufacturers can work through field reimbursement teams to prepare and educate prescribers and staff on the likely utilization management that's going to happen whenever a prescription is ordered, and also offer trial packs to bridge the time between writing the prescription and the patient actually receiving the prescription. As related to treatment of standard of care, manufacturers should consider developing disease education in non-English formats. They should educate prescribers around the 14-day rule and advocate to end the CMS 72-hour rule that sometimes delays processing of tests, and ensure that EMRs include testing notification early in the diagnosis tree, and finally support drug development that utilizes biomarker testing, which can be less invasive, less expensive, more easy to perform, and easier to do in non-urban locations. Some outside the box opportunities here include packaging diagnostics with drugs and various alliances with testing companies. Next slide, please. We've long heard that racial and ethnic minority patients are underrepresented in clinical trials. The FDA now has released a guidance on it and releasing clarification on that guidance as well. According to the 2020 census, racial and ethnic minorities represented 40% of the population in the US and are expected to be a majority of the population by 2045. A higher minority population translates to more cancer diagnoses in these populations. In this graphic, we see new cancer occurrence in blue versus the clinical trial participation in green for 3 cancers: liver cancer, multiple myeloma, and prostate cancer, for 4 different groups: white, Black, Asian, and Hispanic. We see that Black patients are significantly underrepresented in clinical trials in all 3 cancers shown, compared to the new diagnoses in these cancers. Also noteworthy is that while white patients are overrepresented in multiple myeloma and prostate cancer, they are underrepresented in liver, and Black patients are even more underrepresented, with Asian patients being overrepresented. The role of manufacturers here is significant. Clinical trial enrollment is finite, and manufacturers need to establish trial sites with the goal not only of meeting the maximal enrollment, but also with the goal of hitting the racial and ethnic breakdown of trial enrollees that should be closely related to the incidence of diagnosis. Manufacturers also need to address the inclusions of patients with comorbidities in trial protocols, which are more common in SDOH populations. Manufacturers need to work with patient groups and physicians to disavow misconceptions of clinical trials among patients, and to educate minority physicians and physicians who treat minority populations, and encourage them to bring clinical trials to their practices. FDA also just released information on diversity plans that must be completed for any phase 3 clinical trial And while they recognize that there could be exceptions to the diversity plan requirement, they are suggesting that those should be very few in number. They also happen to identify that it will take about 100 hours for a manufacturer to prepare and submit this. They'll be reviewed and could be rejected and given back to the manufacturer before the trial starts. So while it's important that this get done now, FDA has really started to step in and mandate that these types of plans are in place in order to get approval for your phase 3 trial. Next slide, please. Consciously tracking and focusing on enrollment of patients of diverse race and ethnicity does not eliminate the impact of SDOH on clinical trial enrollment. This map is a geographic depiction of where and how many oncology trials are available, with dark purple indicating there are 100 or more trials, the light purple indicating that there are 1 to 99 active clinical trials in those locations. The gold indicates that there are no active clinical oncology trials, but there are oncologists in those areas. And the white indicates that there are no trials in those areas and also no oncologists. So while the use of decentralized clinical trials, also called DCTs, continues to grow, there's still room for improvement. And although DCTs may help the areas in light purple, and maybe even the gold areas by getting more physicians to participate in clinical trials, oncology physicians, what do we do about the white areas? Manufacturers need to go farther. How do manufacturers conduct clinical trials in areas with no oncologists? How do manufacturers utilize existing healthcare sites and train those providers to conduct oncology clinical trials? How can remote monitoring, dosing, administration, and record keeping be accomplished under the FDA guidance? Or does a manufacturer have to stretch outside the guidance to make this happen? Does the need for a hybrid trial with certain aspects like imaging requiring a trip to a distant site alleviate the likelihood of successful enrollment of diverse populations? Unfortunately, I don't have answers to these questions, but these are all questions that oncology manufacturers and other manufacturers are going to have to think about. Next slide, please. And so if we look at the approaches that have been suggested to reduce the impact of SDOH on oncology care, we get a version of this graphic. It's important to recognize that the overall cancer death rate in the US declined by 1/3 from 1991 to 2021. During the same period, the number of individuals living with a history of cancer diagnosis more than doubled from 7.2 million in 1992 to 18.1 million in 2022. Despite the overall progress against cancer, substantial changes and challenges remain. This graphic shows us 3 buckets that many of these changes can be fit into: communication, standards of care, and navigation. Communication encompasses several tactics, including addressing education level of both providers and patients, understanding and implementing cultural sensitivities and culturally sensitive care, and the ability of providers who speak the language of the patient and caregiver. Incentivizing specialty providers like oncologists to work in rural areas with few specialists can not only improve communication and time to care, but can improve the standard of care provided. DCTs and other variations on existing clinical trial procedures are then more likely to reach rural areas and those distant from centers of excellence. Last on our wheel, but first whenever a diagnosis occurs, is patient navigation. If you've ever been handed a cancer diagnosis or other serious diagnosis that is accompanied by a significant amount of information, you understand how overwhelming this can be for a cancer patient. From the start, a majority of patients and caregivers need assistance, and most are afraid or not willing to ask for help. Patient navigation can help address numerous remaining issues, including insurance, financial concerns, childcare, transportation, and other needs. Next slide, please. The cost of health disparities, including cancer disparities, to the US economy in 2018 alone was $451 billion, the majority of which was disproportionately borne by racial and ethnic minority populations. Policies implemented at the site, region, state, and federal level can improve outcomes, as can population health initiatives. The federal government has implemented numerous programs that are focused on providing stable and safe housing, nutrition and food access, and economic mobility. Similarly, federal agencies, including NIH, NCI, and CDC, as well as cancer-focused organizations, are launching and supporting initiatives addressing SDOH. Collaboration across these initiatives and others, and across the nation, to investigate, develop, and trial, and then implement interventions that are meaningful to vulnerable communities, will be necessary to address the impacts of SDOH on diagnosis and treatment of cancer. And I'll turn it back over to you to close, Jessica.
Great, thanks, Tracy. So just some final considerations for when we're looking at social determinants of health. So incorporating SDOH data can provide new insights into disease-specific cohorts, beyond the standard clinical variables that we would normally look at. And when we're thinking methodologically, we can include SDOH into propensity score models or matching to remove biases, or include as independent variables in our analytic models to measure the association between that characteristic and our measure of interest. And as we saw, we can look at composite measures or interaction terms that can be derived from these individual measures to provide deeper insights that might ultimately influence care patterns and outcomes. But finally, or excuse me, not finally, it's important to note that with any use of any real-world data source, it's really important to understand the underlying population represented to make sure we're putting our findings into the right context. And finally, ongoing investment in our system and behavior changes will ultimately improve equity in oncology care that will positively impact health overall. And just, we wanted to say thank you to some of the clients who have allowed us to do some SDOH work with them. And before we take any questions, just wanted to invite you to our webinar our next webinar, which will actually be in January, not in November. We're just taking some time off for the holidays. I know everyone gets super busy, where we'll be talking about the IRA in 2025, what changed, and what do manufacturers need to consider going forward, where we'll be joined by some panelists, including Chris Schott, a partner at Latham & Watkins, and Samantha June, a founder of Way Forward Advisory. Thanks. Happy to take any questions.
Yeah, we have a few in the chat actually. So the first is, how is SDOH data collected in your database and where does it come from?
Great. Thanks. So in the database, in the results that we shared, that data comes from consumer marketing data, which comes from a vendor. And it's collected as part of marketing. So they also sell it to places that are trying to figure out who to target for their product.
Okay, thank you. And what are some examples of provider and patient education that you mentioned in the form of trainings, videos, nurse calls, anything that you're aware of? And if you can answer this, what has been the most effective?
So I'm not sure that I can, thanks for the question. So I'm not sure I can say what's been most effective, but from experience, I see that smaller providers and providers in rural areas frequently don't have normal manufacturer representative interactions. And so while for several years those interactions have been curtailed, there's still the ability to deliver valuable written information to them, to have an occasional meeting, to conduct some type of a continuing education, either in the provider's office or outside of the office in some cases, if your company is still allowing those types of opportunities. I think one of the biggest concerns is the number of patients that are treated in small community oncology practices where testing might be an automatic thought for some of the younger providers, but maybe not for the older oncologists who are used to just putting a non-small cell lung cancer patient in for chemo or chemo and radiation. And so bringing everybody up to that right level, whatever you can do to get there is important. But again, with the levels of restrictions that have recently been suggested and implemented by some companies, written materials, visits by the medical science liaison or whoever your field medical team is, also working with patient groups who still have significant education opportunities with their patient populations is another good way, because if you can get to the patient and empower the patient to speak up to the physician and ask for biomarker testing, push about clinical trials, that's a good way to get around the education aspect as well.
Thank you. Thank you for that, Tracy. We have a few other comments and questions. There was recently some guidance by the FDA to include SDOH in early trials. How is that viewed with respect to designing new clinical trials, and do you see it moving earlier in the clinical trial setting?
I do think that this is an FDA initiative that is not going to go away, and for good reason. And we've seen recently, within the past couple years, FDA actually reject certain trials that have been submitted to them for approval because of the presence of only or predominantly like 95% minority population. In this case, it was a study conducted in China, and the patients were Chinese, and they did not accept this trial submission. So I think that they've recognized that with the global nature of drug development, with companies that have significant partners and companies that are located ex-US, you may get it skewed the other way as well. I think phase one, you're probably not going to hear much about SDOH. I do think in phase two, especially for those trials that and drugs that may be approved under phase two data, I think you're going to have to implement SDOH, look at the occurrence based on ethnic and minority populations, and try to assimilate that into your trial, which means you're going to have to go to places that you don't usually go to get to those populations that have the characteristics that represent the occurrence within the particular cancer. And then when you go for a second indication or a third, you're going to have to do the same thing. So it's going to be a shift in development, but certainly one that's long overdue.
Okay, thank you. Related to what you presented on oncology, Tracy, is the impact of social determinants of health greater within oncology? Or are there other conditions or conditions in particular in which the impact of social determinants of health is greater?
I don't know the proportions. It's a good question. I don't know the proportions of the impact on different disease states, but what I think that we learned from Jessica is that some of these SDOHs start very early, right? So if you addressed the SDOH from the start, the impact overall could be significantly less. And I would expect that diseases requiring specialist care would have a more significant impact from negative SDOH factors, just because of the transportation, the cost, the insurance, the difficulty in understanding what the condition is. That said, type 2 diabetes has, a huge SDOH factor. So, and you don't usually need a specialist to treat that, but it's difficult to understand. It's difficult to implement those changes. So it's almost like a start at the beginning, and it's a high tide raises all boats. But the more expensive and the more specific the condition, would seem to me that it would be a higher burden.
Thank you. We're getting a lot of good questions here in the chat. This question is about gaps in data. So gaps in data, for example, insurance gaps, how is that addressed or viewed and addressed in such social determinants of health analyses? And treatment gaps can be viewed if insurance is continual. Any view on how that gap can be addressed?
So, in an analysis where, using claims data, we're going to be limited to those patients who, have insurance and have insurance claims. There are other data sources that, are rich in SDOH data, publicly available, that you can kind of understand more uninsured or suboptimally insured populations. So, that type of analysis could be repeated in that type of data to kind of understand what's happening in those populations.
Okay. So with the analysis that you presented, Jess, how might a manufacturer or a payer use such findings?
Mhm. Thanks. That's a really interesting question, and and probably one that has a lot of different answers. I think something that might, come top of mind, some, plans include things like transportation, things to increase transportation or transportation vouchers for patients. So if you see that your disease cohort has a higher prevalence of, say, patients who are older and living alone or less transportation access, those might be important services that you might want to make sure you're offering to increase access.
Yeah, that's great. Thank you. So there are, again, this is a bit of a follow-up, but there are interventions in clinical contexts that seek to impact social risk factors and disparities, like you just mentioned, like those transportation vouchers or vouchers for patients that experience food insecurity. But what can payers and manufacturers do with information and what to do with other inequities that are identified?
Sorry, could you repeat the question? My dog was barking very loud.
No, that's okay. So, so you mentioned these transportation vouchers, and there are these interventions within clinical contexts that seek to impact social risk factors and disparities.
Mhm.
Anything else that manufacturers can do with this information when inequities are identified by some of those measures that you mentioned before?
Mhm. Um, that's another great question. I think something that Tracy brought up as well is, understanding health literacy and, the language and how you want to market, or understanding your underlying patient population is going to be critical in how you share the information about your product. So if there's X percentage English isn't their first language or their primary language spoken at home, you might want to make sure you develop materials or understand different, culturally relevant things that might influence a patient's decision making.
Thank you. Any other composite measures that could be useful in understanding access?
Yeah, I think another interesting measure that we're starting to take a look at is understanding frailty and how this might also be related to, some social determinants of health and other needs that arise from that, and how, you can really identify patients who might be struggling to access healthcare or treatment due to, a large combination of factors that are, predisposing them to certain needs, and then age compounding that, and they're not able to access the care. that they need.
Okay. All right. And I'm not sure if we'll be able to answer this, but someone submitted the comment that they've heard the term health-related social needs proposed as an alternative to social determinants of health as a more inclusive and less stigmatizing term. Can you comment on its use and any preferences that you're aware of?
Absolutely. I think I think uh, in this space, we are constantly evolving to, identify the least stigmatizing terms and, how to be as inclusive of all people. The way I think about it is that social determinants of health are not necessarily good or bad. They're just the conditions that we live in, and certain conditions are going to increase your needs and certain conditions are going to decrease your needs. So I kind of think of it almost social determinants of health are an umbrella, and then those social determinants of health would then influence your health related social needs. So if your conditions are such that you live in an area with limited transportation and perhaps poor water quality, your health related social needs would be related to those social determinant of health conditions that are influencing where you live. So I don't know that one necessarily replaces the other, but perhaps is a more inclusive way of, instead of saying like, this is a bad SDOH, just perhaps saying, something, this is a health related need.
Yeah, that's very helpful. Thank you. Do you have anything, Tracy, you wanted to add on to that?
No, I don't know why that hit me.
Okay. Okay. Well, we're all caught up on questions and comments, and we really appreciate your time today. Again, we have our next webinar coming up in January. The next two webinars are scheduled, they just fall on like holiday weeks, so we're taking the next 2 months off of these, but looking forward to the next one. And please reach out if you have any additional questions or comments. And yeah, thanks for your time today. Great job, Jess and Tracy. Really appreciate your insights. Thank you.
Thank you.